welcome you all for today's session on INTERSECT Webinar Series by the Center for IQ, Infection, Immunology and Intensive Care. We are fortunate to have with us two outstanding clinicians and academicians who also serve as co-coordinators for Center for IQ, who share the commitment, vision and collegiality of Center for IQ. I say with this genuine pride that they are not only respected colleagues and academicians, but they are also close friends, and working along with them both is rewarding both professionally and personally. Today's moderator, Dr. Raghav Rao, he is a consultant pulmonologist in AIG Hospitals, Hyderabad. He had training in pulmonary and critical care medicine from PGI Chandigarh. He will begin the session with introducing the topic. His expertise in high acute respiratory care and his clear structured academic style makes him the ideal moderator for today. This will be followed by the main presentation by Dr. Sharada, who is also an associate professor of internal medicine at AIIMS Mangalagiri. She is trained in pulmonary and critical care medicine in AIIMS New Delhi. She brings a rare combination of academic depth and practical ICU experience, particularly in managing complex ventilatory settings. She is running her own ICU in AIIMS Mangalagiri right now. I'm very sure that the medicine residents are trained the best in AIIMS Mangalagiri. So we encourage the audience to post their questions in the chat box during the session, and this will be taken at the end of the session during the discussion. So we are delighted to have you both of them lead this session, and we look forward for an engaging and insightful discussion. Over to you, Dr. Raghav.
Thank you, Praveen. Thank you, ma'am, for being here. A warm welcome to everyone. Thank you for taking time to be here. Today, we'll be addressing a very important topic, which addresses a very critical challenge in the intensive care. Bronchospasm in an intensive care unit would typically significantly impact the clinical outcomes, and understanding its management is very essential for us as clinicians. Today, Dr. Sharada Vinod would help us navigate this complex subject with her experience and insights. The session today would run for about 90 minutes, including question and answers, which we would take up at the end of the discussion. And we will begin the discussion. Over to you, ma'am.
Thank you. Thanks for the very kind introduction, and thank you for giving me this extremely difficult topic, Dr. Praveen. I was, trying to ask my friends whether they have any similar PowerPoint presentations or anything which I can use to, hack my presentation. And they were like, "Oh, this is difficult to, talk about. We've not really had a dedicated presentation on that." So thank you very much for causing me this this what do I say, this stress of the presentation. But I do I do hope that I'll be able to do justice to all the words that you've just spoken about me, and it is scary indeed. I'll just start by sharing my slides. One sec.
Yeah, ma'am, we can see your slides. Yeah.
Yeah. Okay. All right. So I'll start now. I can't see the chat window, so I'm just going to keep speaking. If there's anything, I'll discuss later. So at the outset, I would like to say that this presentation is not going to be very heavy on evidence-based guidelines for how to manage bronchospasm, what are the drugs we use, what are the specific ventilatory modes that we use. I'm not really going into that, because if you go online onto YouTube or any really good critical care channel, that's what you will find the first thing. So when I sat down and I thought of how I'm going to approach this, what came to my mind is this, that the basics of all presentations, all understanding of our, whichever part of medicine that you take, medicine, surgery, anything that you take, unless and until you understand the physiology of things, you really cannot go forward. Once you know the physiology, you know the pathophysiology, and then you know how to deal with problems that you face. So thereby, my approach to this topic is going to be of how we understand the basic physics and physiology behind the problems that we face, and thereby how do we manage ventilatory settings to deal with that. So that's how this is going to go. So to start, to encompass the entirety of mechanical ventilation in bronchospasm, I think we need to know these basic things, which would include the Boyle's law, which would include an understanding of how compliance works, how resistance works, what is a time constant, what is Pendeluft, what is the functional residual capacity, what are closing volumes, what is dynamic hyperinflation. So if we understand this much, Even if we don't know all high-end ventilatory, methodology, even if you just use a volume control ventilation, you will be able to give good quality mechanical ventilation to a patient in severe bronchospasm. This is what I believe. So with that, we start with the Boyle's law. Boyle's law, we know, we studied it in high school physics, that P1V1 is equal to P2V2. That means when the temperature is constant, it is assumed that pressure volume will be a constant. Pressure into volume will be a constant. So this is basically how the ventilation of lung happens, with this as a basis. So with this in mind, let's see how does the lung expand, because when we are giving someone a positive pressure ventilation or whether it's non-invasive or invasive, we are trying to make the lungs expand by giving them a positive pressure externally. But generally what happens to the lung is this. You have a person taking a deep breath. You have a trans airway pressure, which is the airway to alveolar pressure, which overcomes the resistance to gas flow. Then you have a transthoracic pressure, because your alveoli has to expand. And for that, it has to first overcome the elastic recoil of the lungs and the chest wall. So the lungs want to collapse. The chest wall wants to bring it out. So you have a transthoracic pressure, which allows that to overcome that elastic recoil of the lungs. Then you have the transpulmonary pressure, which is extremely important for the rest of our discussion, which is the alveolar pressure minus the pleural pressure. So on the basis of that, when you take a deep breath in, you're going to have the alveoli distending. And then when you expire, which is a passive process, that's when you will have the alveolar kind of coming closer down and eventually reaching an area where they're going to collapse. And you want to prevent the collapse, of course. And then the air goes out and this gas exchange keeps happening. And then you have the trans-respiratory pressures, which just give me a second, please. I'm just going to take a break. 1 second, please. Apologies for that. My dogs were just acting up. Anyway, just 1 second. Right. Am I visible again?
Yeah, you're visible.
Yeah, thanks. All right, so we have the trans-respiratory pressures, which are then needed to overcome the entire resistance and elastance that we have. So this is basically how the lung expands. And we have this graphical representation of this, where you see that you have the alveolar pressure, which is reducing over here, the intrapleural pressure, which is reducing further, and then you have the alveolar pressure increasing, whereby you have the tidal volume reducing and the expiration, which is happening. So from here to here, it is the inspiration, and from here to here, it is the expiration. So please note, and I would also like to give a disclaimer that I understand that there are people of various understandings of this subject in the in the group over here. So bear with me if it is a little too basic for you at some points. So you have the inspiration, which is an active process, and then you have the expiration, which is a passive process and generally longer. And you see that once you inspire and you expire, you're coming back to the functional residual capacity. So we will talk about this as we go further, but we do come to the functional residual capacity. And this is the place where you have the alveolar pressure and the atmospheric pressure, which is equalized, equal positive, equal negative. So after that, you're not going to have further expiration of air. And if you notice, this is the place where everything starts from. Your FRC is where you start things from and end things at. So this is basically what you need to have in mind for a normal respiration. This is not a positive pressure ventilation. This is how a normal respiration works, right? Now we spoke about the lungs expanding. We said that, yes, it does expand. Now the question is, if it does expand, how much does it expand? So what comes into mind over here now is the importance of compliance and resistance. So again, we go back to the Boyle's law, where we know that P into V is a constant. So on the basis of that, lung compliance is basically how much is there going to be a change in lung volume when you give a particular transpulmonary pressure. So if you're going to give a positive pressure ventilation, if you give pressure, how much is the lung going to expand? That is basically what a lung compliance is. But when you look at this, you can't, I mean, it is an oversimplification of things. A patient is not just in isolation. It's not just the lungs in isolation. You have so many other things, so many other dynamic things which are happening. So this is just going to be a static compliance where you're just saying, okay, delta V by delta P. What is the change in lung volume divided by the change in pressure? So dynamic compliance is a change in volume, which is again divided by change in pressure, but this is measured during normal breathing. And you please note this, that this is between the points of apparent zero flow. Again, I have underlined this as apparent zero because it is never ever actually zero. Why? We will speak about that later. So when there is an apparent zero flow at the beginning and at the end of inspiration, in a normal person is where you're saying dynamic compliance. So again, this is still remaining an oversimplification. If you have been ventilating patients, you know that it is not just so easy. But in the spirit of oversimplification, dynamic compliance would then be tidal volume by the delta P would be PIP minus PEEP in a patient who is being mechanically ventilated on a volume controlled ventilation. So when you look at this diagram, basically, this is telling you that this is your peak inspiratory pressure, right? So peak inspiratory pressure is what we're using to measure dynamic compliance in patients on a mechanical ventilator. But it is actually P1, where you have the actual apparent zero in a patient who's on a mechanical ventilator. After this drop here, this is the part which you're actually going to use. And this PIP minus PEEP is, or P2 here, is what you're going to use as the delta P in patients who are on mechanical ventilation. This again is a concept that we are trying to understand, and this may not actually translate to usual clinical practice. This is for understanding that the airflow is much more dynamic than we think it to be. So when you have 2 points of zero flow, the gradient between that is known as the dynamic compliance. Here again, we are needing to understand that dynamic compliance takes into account the resistance which is there in the airways. Thereby, dynamic compliance, whenever you calculate it, is going to be lesser than the static compliance that we understand. So once you have multiple factors in play, the dynamic compliance comes down. So it is not a compliant lung as you think in a static compliance. Also, what you need to understand here is that if you reduce the respiratory, if you increase the respiratory rate, you reduce the time for inspiration and expiration. Again, as we go forward, we will realize that this also increases the flow rates. So if you have, like we saw in the previous, here. So you see that inspiration and expiration, right? So you have a person who is breathing very quickly, who's like, just tachypneic, panting in front of you because of bronchospasm. That patient is having increased work of breathing. That patient is having a shortened total time of respiration, and it is reducing the inspiratory time as well as the expiratory time. So when you have that happening, you do not have adequate time for expiration in this patient, and you do not have enough time for inspiration. So if there's a smaller amount of time that you're having, the flow of the same amount of air is going to be much more rapid. And in that case, there is going to be more turbulence. When you have a turbulent flow, the airway resistance also increases. That will also reduce your compliance. So as you look at static and dynamic compliances, this is from an experiment done in 2016, where they looked at both dynamic and static compliances. So you see that when your breath rates are lesser, your static and your dynamic compliances are much closer to each other. But as you have tachypnea worsening, of course, you're not going to go to 120 breaths per minute in actual practice in patients, but this is an experimental thing to understand that as your respiratory rate increases, the expiratory time, inspiratory time reduces, your flow rates increase, that causes an increase in resistance and thereby an overall reduction in your dynamic compliance. So this was specifically done in patients with small airway diseases like asthma, or for that matter, COPD. So this is why it is important for us to understand that dynamic and static compliance is not the same, and changing one particular parameter on your ventilator is not going to change everything for a patient. So it has to be a holistic understanding of what is going wrong. So if you increase the respiratory rate, you increase the flow rates, you increase airway resistance, and you reduce the dynamic compliance. I hope you understand this. So when you look at a ventilator, when you have pressure scaler over here like this, we're used to seeing this. So this is volume control. So that is why this is flat over here, and you have your pressures which are increasing. You know that this is the P peak or the peak inspiratory pressure. You have your P plat and you have PEEP. Here, when you're looking at static compliance, it is the tidal volume by the driving pressure. The driving pressure being P plat minus P. And when you're looking at dynamic compliance, it is the P peak minus PEEP. So this is what we spoke about earlier, but it doesn't actually reach your zero, apparent zero flow at this point, like we spoke earlier. But for practical purposes, in a ventilator, in the hospital, in your ICU, this is how you will overall look at static and dynamic compliances with the clear understanding that it is not just this that affects the compliance of your patient. Now you have had your airways expand, why they expand, how they expand, we did all that. Now what happens when the airways resist? So you speak about flow rates that we spoke about earlier, and you have diameters. So if you have increasing flow rates, there is increasing turbulence in the flow. That is again inversely proportional to your diameter. That causes increasing airway resistance, which we spoke about earlier. Also, when it comes to the diameter specifically, bronchospasm, which you see in obstructive airway diseases, increased thick secretions, which might be in any patient in the ICU. Mucosal edema may be due to inflammation, maybe due to an infection, maybe due to worsening of an obstructive airway disease. It could be due to something like an allergic bronchopulmonary aspergillosis, which is worsening. That can cause mucosal edema. In a patient who is already on an artificial airway, like a ET tube in place, and you suddenly start having increased peak pressures, you need to see whether there's a kinking of artificial airways. This is, of course, something which all of us know. Extrinsic compression can be because of a tumor, which is lying somewhere in the airways that we are not aware of, or dynamic hyperinflation, which we will speak about later, and then you will understand how that also reduces the diameters. So eventually the diameters, the flow rates, the turbulence of the flow, they're all kind of closely linked with each other, which eventually increases the airway resistance and reduces the compliance, and thereby becomes a more difficult lung to ventilate. So when we look at this from our point of view of a bronchospasm, we need to think of all the other things as well. Bronchospasm, smooth muscles are, overacting, give them SABAs or short-acting anticholinergic drugs to, open out the airways. Secretions are there, need to clean that out, do a toileting. Mucosal edema, you may try steroids. If there is an active infection, you may consider giving antibiotics, depending on what the plan is, depending on the treating physician and the patient's condition. If there's extrinsic compression, you may need to the patient may need to undergo an interventional procedure. If there is dynamic hyperinflation, what do? We look at that as we come forward, right? So please keep this in mind. I would urge you to look at this and kind of loop back and think of how we're going to manage the patient on the basis of this physiology. So we spoke about the physics and physiology. We spoke about resistance and compliance, right? Next, we speak about a concept which we were asked in our DM final examination by one of the greats who came from PGIMS Rohtak, who loves critical care. And at that point of time, we were not really, well aware of what is going on. So I would like you all to know about this. So time constant is actually more of a physics principle and not something which was, indigenous to medical sciences per se at the beginning. So here what you're looking at is if there is a decay of whatever it may be. Now, for us, it is volumes. If there is a decay of volumes, so it is taking, say, one time constant for this to reach 37%. That means 63% decayed in one time constant. To make this clearer or easier, you have an alveoli. The alveoli is going to, release air. There is a certain amount of time it's going to take to release that air from the airway, from the alveolar unit rather, depending on the compliance of that alveolus, the overall, local factors which are there, which are affecting that particular alveolus. Is there a resistance issue over there? Depending on all of this, there is a way in which that particular alveolar unit will lose its air or lose the gas. So one alveolar unit is going to lose 63% in some particular amount of time, and various other alveolar units who do the same. So in a normal lung, up to 95% will empty in 0.6 seconds. So that means in normal lungs, one time constant, or for the entire lung to, completely evacuate the air, it would take 100 to 200 milliseconds. Whereas if you see in a patient with COPD, the time for it to come out, for us to expire, as we know very well that it is so difficult for a person with COPD to just breathe out, it can take up to 2500 milliseconds. Why does this have an impact on us? When we decide a ventilatory setting, that is why we decide to give some more expiratory time to a person with COPD vis-a-vis a person who is probably having normal lungs. That is the importance of knowing a time constant in a patient with COPD or anything else. Please know that this is the reason why we have to know a time constant. Now look at this. This basically looks like a lot of scribbles. Basically, you have a lung unit A, which is the dotted lines, and you have a lung unit B. Now, the thing is that depending on the various compliances and resistances, the filling and the deflation of each unit is going to be different. So either inflation or deflation in a particular amount of time is known as a time constant. That time constant, which is about 63% of decay, is for both inflation and deflation. So we are looking at lung units which have equal compliance and resistance. So they're going to fill in an equal rate. As soon as you start causing any sort of mismatch between them, you start seeing differences. Now, lung unit B has high resistance to filling. So it's going to fill slower compared to lung unit A. Now, lung unit B has lower compliance. So it's going to fill at the same rate. The rate is the same, but you see it is incompletely filled. And now when this incompletely filled lung unit B tries to expire, it is going to also have a longer time constant like this. Lung unit B here has a lower compliance and a higher resistance. So it fills slowly and incompletely. Lung unit A here has higher resistance. So you see it is going to fill in this fashion over here. It's slower. And here you have lung unit B, which has a lower compliance. So it is not going to fill fully, but at the same rate. So you see that just two units have so much of heterogeneity in it. So that is what we need to understand when we are treating a patient with obstructive airway disease. So what is this? This is known as pendeluft. Again, a question which we were asked during our exams. What is pendeluft? Pendeluft basically means that there are certain alveoli which are going to be extra filled because they are faster alveoli. And then there are going to be some alveoli, lung units, which are going to fill slower because they are slower filling, or inflation, deflation, whatever you want to say. So when you have that, once you have an inspiratory hold, then the lung units which are extra filled are going to kind of put air into the lower filled ones, the high pressure to low pressure. That's going to be a equalization which slowly happens. So when you do an inspiratory hold, the initial drop here is because the airway resistance is dropping suddenly. After that, if you see, there is a, like a sloping path which is being followed over here. So when you look very closely, you see that sloping path because you know there is pendeluft, you look for it. So this is slowly the pressure equalization between the various units which is happening, after which an eventual plateau pressure is reached, right? So this slow equalization is known as a pendeluft physiology. So when you have a person, suppose you have heterogeneous lung units, which is mostly the case in most of our patients, you have a patient who's just given a less of a respiratory rate, the patient is just going to be breathing faster, quicker. When you don't know mechanical ventilation, you start giving an increased respiratory rate because the patient is having raised CO2. You're just going to make it worse in a patient with COPD because you're not giving this time for the time constants to, equalize, for a pendeluft to happen to a patient. This is just going to cause more and more, hyperinflation in certain parts, inadequate inflation in certain parts. Certain areas, there's going to be turbulence. Certain areas, there's going to be increased shunt physiology, which happens, again, which we're going to see as we go forward. So that is why we need to give a optimal ventilation to a patient who has an obstructive airway disease. So now we spoke about time constant and pendeluft. After this, we go to functional residual capacity. Functional residual capacity, we spoke earlier. This is the volume of residual gas in the lung at the end of a tidal expiration. So a normal breathing, inspiration, expiration, you've had a final expiration, and that's when you have a functional residual capacity. So this is the expiratory reserve volume and the residual volume in a patient that forms the functional residual capacity. This is associated with closing pressures as well. Why is it important for you to have a certain amount of functional residual capacity, which is so-called normal for each and every individual, which changes with height, which changes with gender, which changes with age. But there is a normative data, and that's what you expect to have in a particular age group. Why? It's important because the certain amount of residual gas in the lung, it keeps your small airways open and patent. When that happens, you're leaving space for some amount of, you're taking time constant into your mind at that point of time. You have the pendulum physiology, which is going on. This helps to maintain an optimal compliance and resistance. Why? We speak about it as we go forward. And this helps in the optimal work of breathing. It helps to maintain oxygen reserves because that is a residual gas where some amount of gas exchange keeps happening even when you're not actively inspiring at that point of time. It prevents atelectasis and thereby it prevents shunting. So that is why you need to have a certain amount of functional residual capacity in every lung. Not much, not high, not low, optimal. So how does it work basically? So this is where you speak about closing volumes, right? So this is basically the airways which you're seeing over here. You have the small airways and then you've got the alveoli coming. So when you have the small airways, you have, when there's a certain amount of volume in here, it is being held, there is a traction which is being there, and therefore it is remaining patent, right? Now, as you start expiring, you see that this traction is becoming more and more, it's reducing over time, and thereby the airways are becoming smaller and smaller. A part of this includes the, you need to remember the Laplace's law, where the pressure or the pressure which is required to keep the airways open is going to be inversely proportionate to the radius. So when you have a reduced radius, the pressure that is required to keep it open becomes higher and higher. So now when you have the airways which are kind of closing off over here, as the volume reduces, your pressure is also slowly reducing over here. Sorry, the radius is reducing over here. So for us to keep this open, to pull it out, for the lung to pull it out, a higher amount of pressure is going to be required. So it is difficult to generate that kind of a pressure at all periods of time. So there is a point beyond which your airways are decreasing in diameter so much so that at a particular volume, this is going to have a collapse of the airways, almost a complete collapse. So this is normal. And this is the maximum volume which you have at which, according to the Nunn's textbook on respiratory physiology, this is defined as the maximum lung volume at which air closure can be detected in the dependent parts of the lung. Dependent parts because that's where you're going to have more of squishy lungs. Your lungs are more soggy as it goes towards the bases. That is where at a higher volume, you're going to have a closure of this. So that is known as the closing volume. So when you have reducing FRC and you have increasing age, this will increase the closing volume. So at a higher volume of expiration, the alveolar units will collapse. They will collapse faster, that means. So what happens? What happens is that, let me just draw this. So you have an alveoli, right? So this was initially how the alveoli was. There was some amount of functional residual capacity. There was, there was traction and this was staying open. Now, when you have an increased closing volume, that means at this volume, your airway has closed, right? So there is more amount of volume which is remaining inside of your alveolar unit. Now, if you want to expand on this, if you want to inflate this, the amount of volume, the amount of pressure that you're going to need to inflate this further is going to be much more. Again, as we come forward, I will show you what that exactly means, but please keep that in mind. So this, what it does is that it makes it more difficult for you to close this. Then again, you're going to breathe in. Again, at a higher closing volume, this is closing. So you have more air, which is filled in over here. So this has become hyperinflated. So I hope this is clear. I'm not the best person who can draw, but yeah, that's basically the point that I'm trying to say. So you have the alveolar unit becoming bigger and bigger, and it becomes more and more difficult for you to, open out that unit every single time. So there is more and more and more of hyperinflation which happens. It can even cause a person to develop a spontaneous pneumothorax in a patient who probably has a significant obstructive airway disease, or the patient who has got uncontrolled severe asthma. But that basically is what overall happens in dynamic hyperinflation. So when that happens over time, that can also cause a dynamic sort of a compression on your airways as it becomes more and more. So that is also a cause for increasing resistance. So that was what we spoke about earlier. So we spoke about intrinsic PEEP, which is because of this increased, dynamic hyperinflation. So you have increasing airway resistance, you have increased closing volume, you have reduced expiratory time, and this causes an end expiratory alveolar pressure to be more than atmospheric pressure, and thereby it becomes more and more difficult for you to expire out, and thereby that amount of air is just staying back in your lungs and causing worsening hyperinflation. So what do we need to do? We need to reduce the resistance when we manage the patient. We need to increase the expiratory time. So that's how we will need to play with the mechanical ventilation when we are trying to take care of a patient who has intrinsic PEEP and dynamic hyperinflation. So when we look at the expiratory breath hold, this is an expiratory phenomenon largely. So when we look at the expiratory hold, you see that this is the PEEP that we are applying to the patient. And above that is the intrinsic PEEP which the patient has, right over here. So this is how you will see it. And you give an expiratory breath hold for around 3 to 4 seconds, and then you measure this to look at the intrinsic PEEP. But the problem with inspiratory and expiratory breath hold is, in ideal situation, it should be a patient who is, very quietly breathing, or the patient is completely, if it is a normally breathing patient. But otherwise, if you want to get the actual intrinsic PEEP, you're going to have a patient who is completely knocked out, sedated, paralyzed. It's only the mechanical ventilation which is doing it. The patient is completely knocked out. And that's when you're going to look at it. That means you're taking away every other factor which is causing an increase in pressures, and you're looking only at the PEEP. But practically, these things are quite difficult at the bedside to actually know when a patient is having only PEEP, intrinsic PEEP, when a patient is having only increase in resistance due to bronchospasm or not. So you have to look at the patient and the ventilator as a unit when you make a decision about a patient. So this is the consequence of auto-PEEP, which I was talking about, that I'll tell you. So what happens is that you have set a sensitivity of the ventilator, or the patient just breathes at -1 centimeter of water, and the patient is about to able to generate a breath, suppose. Now, when you have a patient like this, so you have an auto-PEEP in this patient of 3 centimeters, right? That is the patient's auto-PEEP in the body. Now, this is the PEEP you're giving. This is the PEEP in the patient's smaller airways. Now, if the patient wants to take a breath to trigger, this patient has to do an addition of 1 over the 3 centimeters. So the trigger effort will be 4 centimeters. Whereas if the patient is an auto-PEEP of 10, that means you have to take a trigger effort of 11 centimeters of water to generate a breath, or to take in a breath. So just imagine the amount of effort that is being put on a patient if that is the kind of auto-PEEP that is there. So just assuming that a patient is on ventilator and is okay and there's no work of breathing is wrong. So if you look at this in a patient who has to generate that kind of PEEP over the auto-PEEP, you see that this is where the ventilation is starting. This is where the patient's efforts are starting, and this much is how much the patient has to breathe in. So this is the amount of wasted effort which is there in the patient every time the patient wants to breathe against the auto-PEEP. So that's when we need to reduce the respiratory rate, try and reduce the resistance so that the patient is able to breathe out more easily. It may not always be that easy, but that is what we need to keep in mind when we are ventilating a patient with severe bronchospasm. Now, what do you understand from a pressure time scaler when you're looking at these parameters? You have peak inspiratory pressure that you have P plat, which is after the inspiratory pause when there is no airflow, and this is your P mean, which is the complete area under the curve. So this is how you will see a patient with dynamic hyperinflation if you look at a scalar. So you have, say, there is an intrinsic PEEP over here, right? So every time the patient breathes, I told you, there is the alveoli which is getting in more air, and then more air, and then more air, even more air. So every time that is inside, there is an increase in pressure. There is a stacking with each breath, and thereby you have eventually an increase in PEEP of this patient. So you will see that a patient who is having bronchospasm and asthma, COPD, you've intubated the patient is on ventilator. You've seen that over time, this your intrinsic PEEPs are increasing. There is a stacking of your breath, the volumes, there is a increase that is there. And you see that this curve has not come back to the baseline completely. That also means that there is an incomplete expiration and there is a volume which is still remaining inside, which is causing intrinsic PEEP. So you need to look at each scalar to understand what is going on with each patient of yours. When you have a volume time scalar, you have your inhalation and your exhalation. You have inspiration, your expiration coming over here. When you have this expiratory limb not reaching your baseline, that means there's an air leak. You need to see whether there is a leak from anywhere in the system, whether there's a cuff is, detached or not inflated adequately. You need to see whether that is happening, because when you have a patient who is on ventilator, there might be many reasons for hypoxemia that you notice or sudden desaturations while on the ventilator. So it cannot just be one size fits all. You have to immediately look at the various reasons. So look at your loops, look at your scalars, then you see that this is not touching the baseline, then you think that there is a possible air leak. So when you have a flow volume loop is the next thing which you look at. So this is a spontaneous breath where you have inspiration on the bottom and expiration on the top. So this generally gets flipped when you have a positive pressure ventilation. So this is what we have on a ventilator, where there's inspiration on the top and expiration on the bottom. So you see how this is the loop that is formed, right? So you have the inspiratory flow, you have basically this, like we said earlier, this is the baseline, which is where functional residual capacity is. You're starting from functional residual capacity and then you end at functional residual capacity. You have a tidal volume and then you have an expiratory flow and then you come back to functional residual capacity. So what makes sense is that if suppose there's an air leak, this expiration is not going to come back to baseline. So this is going to end here. Sorry, it's going to end here. Then you have some place where there's some amount of air trapping. So it's not going to come back to functional residual capacity, right? So how is this going to look? You have increased resistance. So when you have bronchospasm in a patient, this is what you look for. This is your inspiration, your patient is expiring out. The blue one is normal. The lighter colored one is where it is pooping because there is so much of resistance, it's not able to come out that easily. There will also be a play of time constants and penduloft as the patient breathes out. So there is increased airway resistance over here. That is one thing that we look at, right? Next, if you have an active exhalation, the patient will continue to breathe even beyond. So this is important too. You may need to see whether the patient is ready to get weaned out. Is the patient requiring sedation? Do you think that the patient is anxious? Do you think that the amount of volume that you're giving to the patient is not enough? Is there a reason why the patient is breathing against the ventilator or extra? You need to look at that. Then you need to see this. Like I told you, there is air leak. So this is going to reach the baseline earlier. This part of the volume is leaked out. And then you have this usual thing which you see where you have secretions and there's just a rattling going on, and this causes a very, very common artifact in most of your loops and scalars. When you see this, you need to make sure that you're taking care of this, because this can even cause auto-triggering. And if that remains, it can subsequently cause increased airway resistance. Now, when this happens, which I spoke about earlier, you have auto-PEEP, dynamic hyperinflation, etc. happening. So the expiratory volume has not come back to functional residual capacity. So this is the amount, which is the residual volume, which is staying there because of the dynamic hyperinflation and leading to an auto-PEEP increasing, and then slowly causing breath tracking, breath tracking and stacking. And then after that, you're unable to ventilate the patient easily. So now we spoke about functional residual capacity, closing volume, dynamic hyperinflation. We spoke about how all of these are interrelated. It is not one thing alone. You're not going to just take care of compliance and leave the resistance. It is not possible. It is not possible to take time constant and penduloft separately and say that, okay, this doesn't have any effect on resistance and compliance. It is not possible to leave the rest of it. If you see every single slide that I spoke about, I have been speaking about the interplay between all of these. So please keep this in mind when we go forward and basically speak briefly about the management. The reason for this presentation being this particular way is that I urge you all to think of the physiology more than anything else. Now, when we come to the management, we have to ask ourselves questions like this. In a patient with obstructive airway disease, what we want and why do we want it? We want an optimal compliance. We want an optimal resistance. We want uniform time constant as much as possible, which is of course not physiologically fully possible. An optimal functional residual capacity for that age, that gender, an optimal closing volume. And why do we want it? We want it because we want normal ventilation. It is not otherwise possible to have normal ventilation unless these things are optimized. We want to avoid VQ mismatch. I will come to a slide later where we see how VQ mismatches happen. We want to avoid hypercapnia because when you have someone with breath stacking in this particular way with dynamic hyperinflation, further VQ mismatch happens, especially in asthma and COPD. You have a lot of VQ mismatch which happens in acute severe conditions. And then you will have, as part of the shunt physiology also, you may have some amount of hypercapnia also because of the increased work of breathing, also because, there is the patient is not able to expire completely and thereby you have the hypercapnia which is occurring. You want to avoid an intrinsic PEEP, which is worsening, and you want to maintain hemodynamic stability because as you know, when there is a breath stacking, when there is intrinsic PEEP, where there is increasing amounts of volumes which are generated and retained in the lung, your overall intrathoracic volumes are increasing, your preload will decrease, and thereby you will also develop hemodynamic instability. So you want stability as well, and that's why you want to take care of this. And eventually, of course, you want early weaning and reduced ICU stay. So for this, what do we have to do is what we learned through all these things so far. Now, when you look at the management of acute adult asthma, most of the studies which are there, you will see that it's in pediatric age groups. It's not really that much in adults. And there are older studies which are there. So what this review showed us is that there is no difference whether you give continuous or intermittent beta agonists in patients with acute severe asthma. The best thing would be to see what the patient requires and give. There is also literature which says that if a patient is on SABA and it is actually working, you will see that there's an increase in lactic acid in the ABG over time. Because only if it goes distally and it's absorbed in the air from the airways into the circulation, that is going to cause lactic acidosis. If it is just going up in the airways and not really entering the rest of the system deep within, and it's just from the upper airways, it's just leaving, that means that the patient's SABA is not working. Of course, this is not rooted in very strong science. It's not something which is continuing to be seen in various studies. It's not something we continue to see in our regular practice. It is not something which affects patients specifically, but it was like a soft pointer which was spoken in previous literature. Again, this is something which was done in children. So they looked at the interface that they tried to give in patients with acute asthma. They tried to give holding chambers versus nebulizers, and that did not make any big difference in patients who were receiving these SABAs. Now, do you have to give both a SABA as well as a anticholinergic agent? It showed that, yeah, well, you may give it, but it increases the side effects that the patient is facing when you give both of them together, even though it did improve your pulmonary function in that patient transiently in the emergency department. This is not about long-term follow-ups. Inhaled corticosteroids, most of the time you have eosinophilic predominant disease in patients who have asthma. This is usually, but not always. So when you look at inhaled corticosteroids versus placebo, adding on inhaled corticosteroids to systemic corticosteroids did reduce the risk of admission from the ED to maybe your ICU or to inpatient stay. What do we generally give according to GINA 2024? You give short courses of oral corticosteroids, and it's seen that oral or IV may work equally well. But in patients in the ICU, we generally do prefer to give intravenous agents. So you can either give prednisolone 40 to 50 mg per day for 5 to 7 days or hydrocortisone 200 mg per day in divided doses. There is also some data which shows that both of this are equally useful and that you do give steroids in patients with asthma acute exacerbations. So now when I spoke about earlier, I spoke about VQ mismatches and shunting. So this was something which I wanted to speak about at that point of time. So what is going to be your target oxygen saturation in a patient who has an acute severe asthma? So the way you treat a patient with acute severe asthma or a patient who has ABPA asthma with bronchiectasis versus the patient with bronchiectasis, which also has obstructive airway disease, is also an obstructive airway disease, versus a patient who has COPD, everything is actually different and depends on the patients. This is just going to be an overall, sort of a thing that we're speaking about, because the heterogeneity of the population is too much to all include in a particular or in one single day or in one session. So when you have a patient with asthma, you will tend to, give a 93 to 95% saturation as your target. So there was a study which was done in 2011 where they found that giving higher doses of oxygen. Doses I say because oxygen also is a drug. Giving a higher flow rate of oxygen found that there was an increase in hypercapnia in patients who were being given more oxygen compared to those who were given lesser oxygen and targeting a saturation of 93 to 95. So we don't need to target 100% saturation in each and every patient who comes to us. So this is why that is. Because when you have, I'm sure you all know about PQ mismatch. So here you have a patient who is having the hyperinflated alveoli, and this is your normally functioning alveoli. So this is low on oxygen, this is high on carbon dioxide, because you have basically got a vasoconstriction which has happened. There is shunting of blood more towards the normal alveoli from where proper gas exchange can occur. So there is VQ mismatch, but this VQ mismatch may actually be beneficial for the patient in some way, because once you give too much of oxygen to the patient, this reflex vasoconstriction is gone. And now you have the carbon dioxide, which is basically going in to the vessels over here. And this places are getting a relative vasoconstriction compared to the abnormal state. So the normal areas where you have potential for good normal gas exchange, that is getting hampered by giving too much of oxygen and ventilating places which are not really functioning that well because of dynamic hyperinflation. So giving controlled oxygen therapy is important in obstructive airway diseases and respiratory diseases in general. So once you start working with respiratory, patients with respiratory illnesses, you realize that just don't give oxygen to everyone, the way you feel like. So it is important for us to keep this in mind when we administer oxygen to patients. What was the role of HFNC? Because it came up in a big way, especially once we had COVID. So HFNC was tried for everything. It was found that HFNC application to patients with asthma improved their dyspnea, but it did not reduce their overall intubation rates and the length of hospital stay that was there between the two groups. Do you have to give antibiotics for exacerbations of asthma? No. Only if there is an active infection, only then will we give acute exacerbation. You will give antibiotics for patients with asthma. And I'll look forward to Dr. Praveen adding to this later on, since he's an infectious disease specialist. And I hope that he'll agree with me. So unless you have an infection, you're not going to, really be giving asthmatics antibiotics. Now, what is the role of magnesium sulfate? There was an old trial known as the magnetic trial, where they looked at giving magnesium sulfate to patients with asthma. So you know that magnesium has a lot of downstream effects. And the most important one in patients with obstructive airway disease, especially asthma, is that it has a role as a calcium antagonist. But still, to date, there is no specific recommendation that we should give magnesium sulfate to patients. You may give it to patients who have severe asthma, not responding to other forms of bronchodilation. You may consider giving patients magnesium sulfate. This is the only thing that you can say at present with respect to magnesium sulfate. Now, when it comes to non-invasive ventilation, it is very interesting to see that in patients who are asthmatics and have an acute exacerbation, there is at present no recommendation per se for giving non-invasive ventilation. Of course, this is slightly dated, but at present also, we do not have that kind of an indication to say that, okay, you do give non-invasive ventilation to patients who are asthmatics, unlike patients who have COPD where NIV is something which we do give upfront. So when you have a patient who is having an acute severe asthma, who's turned up to your, to your ICU, you may try non-invasive ventilation if the patient is not extremely tachypneic, has a respiratory rate of say 24 or a little lesser than that. Patient there's no clear pH which is defined for a patient who is asthmatic. So it would be something which would come from your, experience treating asthmatics. Patient has to be, and this is for any patient who's going to be on NIV, the patient has to have sensorium which is fine and the patient is able to tolerate non-invasive ventilation. And after an hour of using non-invasive ventilation, the patient should have symptomatic improvement. The saturation should be normalizing, and the patient should not have worsening in your blood gas analysis in the form of worsening respiratory alkalosis or acidosis. And there should not be worsening patient general condition. And when you're putting a patient on invasive mechanical ventilation, which is generally what we end up doing if the patient has acute severe asthma, you need to see whether the patient is developing auto-PEEP, whether the patient's compliance is reducing because of the increasing airway resistance, and how is this worsening every single time that you go ahead with the patient's ventilation. So it has to be that the initial time you're going to do ABGs maybe every 1 or 2 hourly for at least maybe, say 4 or 5 times and see how the patient is improving on a particular setting. If you have made a change in setting, do not repeat your ABG before 30 minutes. I mean, this is just common sense stuff, which I'm just talking about. And you need to keep your patient under close monitoring. It's not that you put a patient on an IV or an invasive mechanical ventilation and leave the patient to, to just get all right. So when you have overall, when you're looking at a patient in asthma exacerbation, you would try to give a lower respiratory rate. You will not give excessively high tidal volumes. So most patients do well with just say a 6 ml per kg body weight or 6 to 8 ml per kg body weight, which is enough. You don't need to give too much of tidal volume just for the sake of improving the patient's overall minute ventilation. You need to try and increase the inspiratory flow, but not reduce the inspiratory time too much. It's again a balance that you have to see from patient to patient, because we spoke about time constants. And give more of an expiratory time so that there is time for the patient to expire to reduce the dynamic hyperinflation. And PEEP application, even though you think intuitively that you have to give an extrinsic PEEP to all patients, in whatever previous data that was there is no decided improvement in giving extrinsic PEEP to patients who have asthma exacerbations. So it has to again be tailored from patient to patient. And you can see that the pressures are peaking here in a patient who has asthma. You may be also okay with, accepting higher peak inspiratory pressures in a patient who is having an acute severe asthma and not just get worried by that. You should be more concerned about the PEEP plat in that patient too. And peak inspiratory pressures may be okay for a while in a patient who is having an acute severe asthma till the patient is, kind of getting settled with the management that you're providing. This is the dynamic hyperinflation, which I'd already been shown you earlier as well, where you see that this inspiratory pressures keep increasing, and then you see that this is kind of becoming peaked up completely over here. The pressures have stacked, the breath is stacking, the volumes are stacking. So this is something you need to look for in patients who are receiving mechanical ventilation. Now, persistent hypercapnia is also something that is okay in patients who have asthma. Again, we do not have exact cutoffs. This is not like the ARDS net protocols that we have for ARDS, but you may be okay with hypercapnia if the patient is maintaining the overall pH and there is no significant acidosis, because you may not be able to give high volumes, especially initially in a patient who's having acute severe asthma. There are some non-ventilatory managements which are there, like the usage of ketamine. There is usage of inhaled volatile gases like sevoflurane in patients who are asthmatic, but we do not have guidelines at present to use it in regular practice. Heliox was something which was spoken about earlier, and the thought behind that was that we spoke about turbulence of flow. So Heliox kind of causes laminarity of flow, thereby reducing the airway resistance and thereby helping improve the ventilation overall. But at present, we do not really have guidelines for routine use of Heliox. Similarly, with ECMO, we do not have adequate data to say that, you need to give ECMO to patients who are having hypercapnia, but it is something which we can try on a case-to-case basis. You can try ECMO in patients who are having persistent hypercapnia. You can also use ECOR. Now, coming to acute exacerbation of COPD, this would be a slightly different set of patients who are not exactly like asthma. But do keep in mind that with the evolution of time, we have seen that patients who have poorly controlled asthma over time can develop features suggestive of COPD, which is why it's known as a group called COPD-A or COPD asthma in the newer GOLD guidelines. So you see that in patients with COPD, there is a clarity that no matter what the initial pH of the patient, if the patient is conscious, oriented, the patient is able to listen to your commands, the patient is able to, there are no severe craniofacial injuries, the patient is able to have an oral facial mask, you can apply either a critical care ventilator and pressure support ventilation or a home BiPAP machine and use a BiPAP for the patient in an acute exacerbation of COPD. But do remember that if there is a patient who has acute exacerbation of COPD with hypoxemia, and if suppose you're requiring more than 50% FiO2 to be given to a patient, a home BiPAP machine will not allow you to give more than 50% FiO2. So more than that, you need to put the patient on a critical care ventilator with a pressure support ventilation, or you may need to intubate the patient depending on the condition of the patient. Also, it is important that in a patient who has acute exacerbation of COPD, your target saturation is 88 to 92. Similar idea of not giving excessive oxygen to the patient, which will worsen the shunts, which is one thing, and the VQ mismatch. Also that it takes away the respiratory drive, which is something which most of us already know. Okay, so after this, what we do is we give the patient, you give your bronchodilators. Steroids are not really found to improve the patient's outcomes. It actually, it just helps you at that point of time. It does not overall reduce these rates of rehospitalization or recurrent exacerbations in a patient of COPD, unless and until it is a COPD-A or an ABPA, which has gone into a chronic obstructive phenotype, whereby you need to give long-standing steroids to these patients. Otherwise, you do not give long-standing steroids. You may give it in the ICU to the patient at that point of time. So for a patient who has a pH of less than 7.35 and a PaCO2 of more than 45, you do have a strong recommendation to give upfront non-invasive ventilation to these patients, and you give a BiPAP to this patient as well if required. So what are the ways in which you go forward? You have a patient who has COPD, who has come to you with an acute exacerbation with a less than 7.35 pH, PaCO2 more than 45, like we discussed, and a respiratory rate of more than 23, which is persisting after you gave bronchodilators, you gave the patient oxygen therapy. In spite of that, this is persisting. You will give non-invasive ventilation to this patient. Like I said, there should be a good facial, uniformity, if I may say, and there should not be a deformity that allows the application of the machine, the mask onto the patient's face. There is a relative contraindication that if the pH is less than 7.15, you do not use it. But to be honest, patients who are chronically hypercapnic and have used home BiPAP before, have been intubated before, they may come to you with a pH of 7.15, 7.12. You can still give them a trial of non-invasive ventilation, provided the patient is able to manage their airway and the GCS of that patient is good. Only then you can try that. Also, if suppose this patient is on home BiPAP and the patient is using nasal prongs at home, suppose, or a nasal mask, you would not go for that mask. You would go for a full face mask, because the chances of, mouth breathing and leak is much more in a patient who's coming with an acute exacerbation. So you're going to use a full face mask. Once you have this patient in front of you, you can't just leave this patient. Like I said earlier, you need to start with an EPAP, IPAP, at least 3, and start at say 15 and try to go up to 20. Maximum you need to give say up to 8 of EPAP and 30 of IPAP, not more than that. More than 8, if suppose you're thinking that there is a obstructive sleep apnea or an OHS going on along with it. Titration has to be done depending on how the patient is responding to the PAP that you're giving, and the patient is able to have normal respiration without ineffective triggers in between. So the patient is adequately able to have good thoracoabdominal respiration, a normal respiratory rate. There might be some amount of tachypnea in a patient who's chronically having COPD, or chronically the patient is sick. On home BiPAP, don't expect that the patient is going to have a respiratory rate of 15. But if there are no ineffective triggers, the patient is able to breathe on a BiPAP machine or a PSV ventilatory mode, and if there is an improvement in pH and an improvement in blood gases in the next 1 to 2 hours, then you may continue the patient on non-invasive ventilation. But if it is beyond that, if the person is continuing to have worsening pH, the patient is having tachypnea, which is persisting, the patient is having worsening sensorium, which was not there prior to this, then you may need to consider invasive mechanical ventilation. So what are those patients who are likely to not or likely to fail once you've given non-invasive ventilation? It's quite intuitive. Someone who has younger age, who has a lower activity of illness, who is more cooperative, who is able to better coordinate their breathing, less air leaking, better dentition, good facial structure. Patient is tachypnic, but not too tachypnic. There is hypercarbia, but not too much. There is acidosis, but it's better than 7.1. And there is an improvement in gas exchange, heart and respiratory rates within the first 2 hours, which is why we need to do an ABG in the next 1 to 2 hours in patients, instead of just, sitting, waiting and watching and expecting things to just be fine. So to put together what is the indications of NIV, or what is the way you approach NIV in patients with COPD, you use either a BiPAP or a pressure support ventilation. You give it to all acidotic patients with the acute exacerbation, even if there are no absolute contraindications. You need to repeat blood gases in 1 to 2 hours. You can use your pH, your Glasgow Coma scale, and your Apache score to help you predict failure. You need to look at leak, asynchrony, and other complications and acceptability by the patient before you take this forward. And of course, if the patient fails, you have to intubate the patient. And we then go back to the physiology and physics of it all when it comes to a patient who has obstructive airway disease. By saying that you need to have your Boyle's law in place, you need to have the compliance in place, you need to remember that the patient should have, you would rather have a larger, it starts from there. Once you have a patient who doesn't have a good sensorium, who cannot tolerate non-invasive ventilation, you will intubate that patient. Once you're going to start with intubation, you're going to start with the resistance through the tube. So don't take like a 6 or 6.5 ET tube to put in if there are no other contraindications. You want a wider bore, gauge ET so that the resistance from right here you can reduce. You want to give the patient a tidal volume which is 6 to 8 ml per kg, which is generally okay for most patients, unless of course the pressures are too high, the P plat is too high, and then you need to reduce the pressure. And then you will accept some amount of hypercapnia in an asthmatic patient, because you will be having, as long as the patient is hemodynamically stable, the pH is fine, the patient is doing well otherwise, and over time you may see improvement in the patient. When you have a patient with COPD or asthma, any obstructive airway disease, you will try to give, especially with COPD, you try to give them a lesser respiratory rate, adequate time to expire, keeping in mind that you have time constants, you have pendeluft, you have dynamic hyperinflation, you have critical closing volumes, and all of this will improve once you give the person time to expire, and that will overall finally improve your compliance and resistance. And that's how you would take this forward in a patient who has COPD or asthma. So I hope that this helps you to what do I say, approach your patient a little differently compared to what you would have been doing so far. And I'll end now. Thank you. Thank you to Dr. Praveen, opportunity to me and to the coordinators for allowing this space.
Yeah, amazing. That was a very comprehensive review, ma'am. One of the most important lesson is just because someone is having CO2 retention, don't increase the respiratory rate. Just like that for all the patients, especially with COPD physiology, it will worsen. So before coming back to you, ma'am, I would like to involve Dr. Raghav, because I think his thesis is on adaptive support ventilation, which calculates the expiratory time constants and IE ratios, thereby adjusts the respiratory rate. So recently there is a study which shows that adaptive support ventilation is not better than a routine critical care physician, whatever settings they are setting. But what about the COPD subgroup? Dr. Raghav, do you think that adaptive support ventilation will be smarter than physicians who are setting the ventilatory settings bedside in COPD subset?
Thank you, Praveen. Actually, my thesis wasn't on ASV. My thesis was NIV NAVA to NIV PSV. Juniors was on NIV ASV and NIV NAVA.
Yeah.
So my thesis, there was no obvious benefit with NIV NAVA compared to NIV PSV. When in Dr. Bharat, who was my colleague junior, NIV with the ASV was not superior to the conventional NIV PSV. Only the number of maneuvers that were needed were reduced. Overall, if we really monitor them very carefully as we do, like every hour or every second hour with a blood gas analysis, probably at least what our thesis showed was these weren't superior to the conventional ones.
Yeah. Sharada ma'am, do you have any experience of using Heliox or even Dr. Raghav?
No, I haven't used it. I mean, it's just whatever you've read that it is supposed to help. There's no harm in trying it, but it's like something like a salvage thing from whatever I've read so far. But I don't know if Dr. Raghav has any other experience. I would love to hear.
Oh, Praveen, I think it's more a theoretical thing or something which we read in textbooks. I'm not even sure if it's really available in India.
Yeah, no.
And the only subgroup where probably there was some benefit was when it was used as a driving agent for nebulization in COPD. It would just reduce the peak pressures and probably decrease hospital admissions. And one major limitation here would be the FiO2 requirement in these patients. it would always be 80-20 ratio or 70-30 ratio. Increasing beyond this would be counterintuitive to us applying Heliox.
Okay, great. I'm an ID physician, so if I ask something stupid, I'm excused, I guess. So, so, ma'am, so do you calculate this inspiratory and expiratory time constants in your patients to set a E ratio or respiratory rate routinely? Do you do
No.
that in your practice?
No,
Yes.
no.
So,
I mean, it's something that, I mean, when we were doing medicine together, you and I don't think we did any of these things at all. Our seniors taught us, we did it, and it went on like that. But over time, you start reading, and then you realize that these things exist, and it helps you understand why some patients improve to a particular mechanical ventilatory setting vis-a-vis some patient who doesn't improve, and then you can make subtle changes in each patient. I really feel that you have to take the ventilation and the patient as a unit, and unless and until you do that, it's not going to be the same. So I don't really calculate time constant. I think it's more of a theoretical understanding of why it works in this particular way, and thereby giving more time for patients to expire and for them to get better. So but I think, Dr. Raghav, do you calculate time constant? Yeah, I mean, it's something I'm just, I love to tell my residents also that this is something you should understand, and Pendeluft is a phenomenon you should understand when you're ventilating a patient. So, yeah.
I think it eventually boils down to us seeing those scalars, expiratory time.
Yeah. Yeah, and I
that
also feel that, when a lot of these newer modes of ventilation came in, everyone was just so excited about doing all those things. But eventually you come back to whatever is the mode you're most comfortable with and you are best understanding. And I think your outcomes of patients is best with that. Of course, there are reasons to use particular modes, but, it's not needed for every patient.
But
okay.
I think the ASV mode Hamilton ventilator gives the expiratory time constant, I think.
Yeah,
Is
yeah.
it? I
Based on
haven't
that,
used,
yeah.
no, I haven't used Hamilton, no.
So I would like both of you are like pulmonary critical care physicians. So I would like to ask, have you ever happened to see a patient with, for example, asthma who is having refractory bronchospasm? You're not able to ventilate because the airway pressures are quite high. The ventilator is not delivering. And then you eventually understood there is a mucus plug and you have to do an urgent bronch to remove that big mucus plug in the airway. Has it ever happened with any of you?
So I think we'll be able to understand that with PEEP and P plateau and maybe simple auscultation.
Mhm.
Yes.
And I guess now with, I'm sorry, did I interrupt, Dr. Raghav?
No,
Can
no,
I?
you can carry on.
Yeah, so I think with the advancement of focus in the ICUs, our understanding is quicker. We don't have to wait for X-rays to come in. You can see that there's no movement on one side, movement on the other side. There's no pneumothorax. You kind of know that this is what is happening. So, I mean, again, it's the patient profile. You know that this patient has been having increasing secretions for some time, and then this happened. So, it's, I guess that is not something that, you would miss.
Like in a setting of emergency, for example, a patient with infection and acute exacerbation of COPD or asthma, with almost silent chest, whose hemodynamics are very borderline. You want to intubate this patient, but the moment you keep on a ventilator, because the peak pressures will reach, it will be difficult to ventilate that patient. And when you are sedating this patient, again, that deep inspiratory effort will go. So with the borderline BPC can crash. So how do you deal with these situations where you have to intubate a patient with borderline blood pressure and very high airway pressures? Uh, there is a problem we are anticipating in this patient that after intubation he might crash. So do you do anything specific in these patients? I want to hear whether you use ketamine in such patients.
Of course we do, because I mean, I think you're tailoring the questions for the answers that you want. So, of course we do use ketamine in those patients. Of course, there are no other contraindications. And personally, something which has worked for me very well with patients who are difficult to ventilate is to use a Bain circuit and ventilate them on that until the patient settles down, and then kind of put them onto a ventilatory setting which works for them. So that is something which has helped. because we don't really get ECMO that easily in the government sector to, do for all patients, or an ECOR for that matter, which would be something that we can do as a bridge till the patient improves. But that's not something that we get very regularly. So BAIMS works very well, where you're able to manage the PEEP as well as give tidal volumes to the patient.
Okay. Actually, with the ECOR, there is a recently published RCT, ma'am, Vent-Ever trial, where actually compared to non-invasive ventilation, the ECOR group has actually done very poorly. The mortality was 22% versus 0%. I think technical issues will also be there. So we'll be very excited to do ECMO in patients, but I guess there are other issues. So conventional management is also, there are no difference in the ventilator free arms, even in the invasive mechanical ventilation arm. So it's very easy to